Hey, Deserving listeners, it's time to continue watching the Viall Files with Nick Viall, who is interviewing Dr. Darcy about the Johnny Depp Amber Heard trial and talking in general about mental health and personality disorders. This is the Psychology in Seattle podcast. I'm your host, Dr. Kirk Honda. I'm a therapist and a professor. Let's watch.
What you do anywhere is what you do everywhere. So he didn't just get caught in a fly trap. He's attracted to women who behave a certain way. And it may be that these others, his exes, just didn't have it at the level that she had it at. Now, to address your question, people with a personality disorder, they don't necessarily show it to the world. So they can be high functioning. They can be successful in life. They know that they can't act like animals with certain people. And so they keep their shit together at work. They keep their shit together in certain...
Yeah, absolutely. Most notably, people with narcissistic personality disorder can come across as a pillar of a community where everyone loves them. But they go home and they terrorize their spouse and or their family with their issues. I won't go into the reasons why that happens. It's not a choice usually that the narcissistic individual will engage in. It's their defensive structure and the way it works out. But she says that they know that they can't act like animals. And yeah, I mean, that's one way of putting it. I tend to find, and certainly that isn't accurate, it implies that the individual, the personality disorder, has some sort of volitional control over how they see the world and how they behave, and without insight or recovery, these individuals have very little rational insight into what's happening and sometimes a complete inability to reflect on their emotions and their behavior. They're just reactive, and they don't have time or the capacity or the emotional intelligence or the safety to even look back just 5 minutes ago at their behavior, let alone a few months ago. So this idea that somehow it's under their control or they make a choice, I find not to be an accurate conceptualization. But also to refer to them as acting like animals. Well, we're all animals, so it's not really an insult to say that, but I'm waiting for, because I heard, and I actually read the comments below, that there's a lot of anger at Dr. Darcy because of supposed stigmatization. And, I've heard a little bit of it thus far, but nothing tremendous, and certainly not on the level that I usually hear.
Disorders that she meets criteria for. Manipulation is a huge component to the borderline, a huge component.
Okay, well, so that's a little stigmatizing, but it's not unusual. In fact, anecdotally, I would say that most clinicians would absolutely consider people with borderline to be associated with manipulation. And it's true that these individuals can resort to manipulation or it can come across that way, but that's not often their intention. Briefly, what I'll say is that, like, when someone with histrionic is triggered, when they feel like they aren't getting enough attention, which is pretty much all the time, and they equate attention with safety and worth and lack of abuse and lack of abandonment. So they, falsely connect these two things and ignore all the other signs of closeness. So they're hyper vigilant about attention seeking, and there are various different types of that anyway. And so when they're not getting attention, for example, if their partner is getting attention, such that like they're getting a deal with Dior, for example, then the perception is, I am about to be abandoned. I'm about to go into a lot of danger, and I have a spike in anxiety because I misperceive the situation as if my partner's getting attention by Dior, then I'm not getting attention, and I'm going to be obliterated. And a tremendous amount of fear kicks in. It doesn't make a lot of sense, of course, but it is the schema that they operate from neurologically. It all happens subconsciously. And so then you might look to your partner and say, you're a piece of crap. I can't believe that they would want to work with you. You're not a fashionable person. You might even sabotage. Okay, from the outside, it looks manipulative, and it is, I suppose. But the reason for it is because they're deeply, deeply afraid. the analogy that I always give is that you're teaching your daughter how to ride a bicycle. She's 7 years old, and you're holding onto the bike. And then you let go of the bike. And she's like, yeah, okay, let go. I can do it on my own. And you let go of the bike. And she's like, I'm doing it. And then she crashes hard into the road, and she skins her knee, and she's on the ground, and she's crying, and you run up to her, and you say, oh my God, you were doing so well, but are you okay? It looks like your knee is... And she screams at you. Your daughter says, I hate you. You did this to me. I never want to ride a bike again. You always do this to me. You don't care. You don't love me. I hate you. Okay. Now, not every 7-year-old is going to do that, but you could imagine a 7-year-old at least being in that direction. Okay. So in that moment, if you just took it for face value, you'd say, my daughter's a psychopath. Like, what? You asked me to let go. You're blaming it on me. And all the things I've done for you over the past 7 years are erased because you're in a little bit of temporary pain. And it's not even that bad. Like, if you just look at it literally, then you would think your daughter's a psychopath, that there's something deeply wrong with her. But we all understand, because we have enough experience with this, that your daughter is scared, is in pain, and is freaking out. And some of us will attack people close to us when that happens. So it's the same for people with personality disorders. It's the same for all of us, but when you have a personality disorder, you are a lot more likely to feel that intense fear and pain by things that to you make no sense as to why they would feel that way, but they do, and then they react in a way commensurate with that feeling, and it's all out of their awareness. And from the outside, it looks like manipulation. Like we could apply that to the 7-year-old. One strain of what you're getting from the 7-year-old is, you're trying to manipulate me into believing this is my fault when it's not my fault. It's your fault because you fell down and you asked me to let go. And plus, we don't have to talk about fault. It's not, you wouldn't call it manipulation. You would say they're freaking out. Well, for people with personality disorders, they are freaking out in that way very frequently, depending on their level of insight, depending on their context, depending on their recovery.
How, as someone in your field, how do you approach or diagnose when you have two people in a relationship who are being abusive to each other or just being toxic to each other? Like, there seems to be a lot of, finger pointing.
And the substance use element.
Yeah. And so how do we look at that? I think I probably inappropriately used the word co-abuse a couple of weeks ago in terms of how does someone in your field, you sit down with a couple, they start talking, and then after 15 minutes, you're thinking, you guys are terrible to each other. How do you look at that situation?
By the way, in my long conversation with Nick yesterday in person, he told me, I think he's referring to this, that when he was talking about Johnny and Amber, he said co-abuse or mutual abuse. And he brought that up as a possible conceptualization, I think, of their presentation. And he was attacked online by people saying that's not a thing. And it is a thing. We even heard the super expert Dr. Hughes talk about it, I believe. I'm pretty sure she did. But yeah, it's absolutely a known phenomenon that you will have mutually abusive relationships. We want to be very careful about identifying those, especially in a quick assessment process, because we could and often would be blaming a victim. That often in a one-way abusive relationship, the victim will fight back sometimes, or they will defend themselves, or they will be driven to be violent at times. They might even be manipulated by the abuser to do that so it can justify continued abuse. So just because we see what looks to be mutual abuse, meaning that each person will alternate between dominance and control and intimidation and violent and other kinds of psychological, emotional harm and consequences to disobedience. We heard Dr. Hughes talk extensively about that process, that intimate partner violence is the imposition over time of consequences to disobedience, essentially, whether it be physical, emotional, psychological. And over time, the victim becomes more and more beat down, more and more potentially gaslit, more and more lower self-esteem, lower autonomy, lower control over their lives, lower ability to be themselves. And that pattern over time is what we call the abuse intimate partner violence pattern. But when you have mutual abuse, then you have both people doing that alternatingly to each other. And you can imagine that it's kind of rare, but it does happen where one person is beating the other person down. It could even be in the midst of one fight where they alternate, where one person is putting you down. You're a piece of crap. You're a piece of crap. If you don't do this and that, then you're going to get it. Okay. And the person receiving that message is afraid and is being dominated. Then boom, it switches, or a different fight. And the other person is doing that. You're a piece of crap. I'm going to slam things around and you better be afraid of me. Or one person is more physical, the other person is more psychological. That can happen. But again, we want to be really careful when we identify those. And in my field, that conclusion is after ruling out one person being the dominant person, meaning that they're predominantly the dominant person. We have to rule out that definitively before we can come to that conclusion, because, like I said, we don't want to blame victims. But it's absolutely a thing.
When you have somebody, when you're in a situation where one or both partners are at least abusing substances, if not in a full-on addictive problem, you have to fix the addiction before you can deal with the human beings. The addiction needs to be handled first.
Okay, so this idea has been plaguing me since the very beginning of my career. I won't go into detail. I actually talk about it in my book on supervision. It's in my first chapter. I had my very first, I'm 25 and I have a supervisor, and I don't know, it played into that whole thing, and it was a very difficult time for me that psychologically plagues me to this day. But anyway, there's this notion in our field that goes back a number of decades that she just said, which is you can't do anything in therapy. She didn't say this directly, so maybe she's not saying this actually, but I've heard other people say this. I don't hear people say this so much anymore, but I still do, that you can't do therapy until you recover from your addiction. And I believed that for the first number of years in my practice, because that was the prevailing dogma. Over time, I learned that, yes, it's true that if someone is in the throes of an addiction, particularly if they're intoxicated beyond a certain threshold in session, then the therapy is going to not work or be very minimal in terms of its effectiveness. The person, if they're trying to work on their emotional regulation, well, when you're drunk or you're on certain drugs, it makes it nearly impossible to have any kind of control over your emotions or to remember what you learned in therapy. If you're highly intoxicated in therapy, you're not going to remember things. I've had clients who are fairly high on marijuana, and in those situations, I wonder if it's helpful at all to them. So there's that. But a heavy caveat to this, which is that usually, if not the vast majority of the time, the substance abuse is coming from a place of trauma, either physical trauma or relational trauma. And to say you must recover before you can work in therapy is potentially a catch-22, because in order for them to recover, they need therapy. So it depends, but someone with Johnny Depp's level of substance abuse, I could absolutely see a therapist being of sound mind when they are saying to Johnny Depp, you've got to at least be 3 months into a sobriety program before I'm going to work with you, because the level of substance abuse I'm hearing, everything that we do in therapy is not likely to work. The other reason why we have this dogmatic idea is that in the distant past, say 40, 50 years ago, there was this huge divide, and there still is for the most part, between psychotherapy, counseling, psychology, and substance abuse treatment. The psychotherapy community kind of looked down on the substance abuse treatment community and would consider them, well, you're not real therapists, and it's ridiculous, of course. And there's more conjoining of these two. In fact, in my program at Antioch University, we have mutual certifications in both marriage and family therapy and in chemical dependency treatment. And you can you can double dip your hours and become certified in both at the same time. But anyway, so what this led to was a culture of ignorance in the psychological community of the wisdom that the substance abuse treatment individuals had. because they looked down on them. And what would happen is that psychotherapists would engage in therapy with people that were in the throes of a major addiction and just ignore it and would not consider it important to address and think of it as just a minor symptom of their deep psychological issues rather than in need of a treatment-specific program for substance abuse. And so over time, we started to learn that that idea was harming a lot of clients. And so this very quick dogma was applied where we all just kind of agreed, substance abuse people and psychotherapists and psychologists, that we're just going to, whenever we get someone with addiction, we'll just send them to people that treat that sort of thing, substance abuse. And then when they're all fixed, then we'll work with them. Because there were ethical accusations of ethical violations to psychotherapists that were engaging in that kind of work with people in the throes of an addiction. And so there was this very simplistic rule and idea that permeated our culture very quickly and denied all nuance to the whole subject. So when I get a client and I start to assess them and I realize that they have a substance abuse problem or signs of that, then I don't, because what a lot of therapists will do is they will say, oh, okay, go to treatment and come back to me when you're well. And that could be really disruptive to someone. One, it could be really hurtful to them. They might not really understand why you're doing that. Also, it's not that easy. Anyway, point is that when I get someone like that, I might do that, depending. But usually what I'll do is I will because the other aspect to this is some people, it takes them a long time to be convinced that they have a problem or comfortable enough to seek treatment. Who better than me to help them with that, right? I can help them to understand that they have a problem in a way that they can perhaps digest and is palatable to them. And I know exactly what sort of program they need to be in because I've actually worked in chemical dependency agencies. There was a time in my career when a substance abuse treatment center actually employed me as someone who did psychological assessments and therapy. And I learned a lot in that experience and have absorbed that whole field, if you will, and had to overcome a lot of my assumptions about substance abuse and clients. One being that outside of substance abuse treatment, I'm used to clients telling me the truth. But in substance abuse treatment, the denial and the shame can be so severe that a client can present very truthful, and they can be 99.999% of the time truthful with me and open to me. But when it comes to admitting that they're still using Percocet, for example, an opiate, they will convincingly lie to me, and I'll just proceed forth as if they're telling me the truth. It's not my job to confront them on that, but I should know, or I should have some question marks around things like, well, I don't know if that's exactly true. And I learned the hard way that my assumptions from the psychotherapy world don't always apply in that way. Anyway, so I will work with people when they come into me. And so one of the things that we might find is that yes, they need to be in a 12-step program or a substance abuse program or rehab program. And those programs take a long time. It's not like you just go for a month. The way I feel like a lot of people think, it's just like, well, go away for a month and come back to me sober. It does not work that way. It's a lifetime of treatment if you suffer, especially from the addiction that Johnny Depp, I think, has disclosed that he's had. And so just the idea of coming back to therapy, having been sober. Anyway, so I would say, hey, I think you have an issue. I want to work with you on this. We can talk about these other things, but I think we're going to be hindered by this. And I think you deserve to be sober because I think there's a lot of consequences to your use that is really harming you independent of what we're doing here in therapy, And if they're like, well, I don't know, I'm a little scared of that, then, I can work with them on that. It might take a few months for them to gear up to doing that, and that's what I'll do. Then even when they do enter treatment, once they start to do that, I'll work with the treatment team to devise an overall plan that coordinates all the care. And I might find, not always, but often do, that in conjunction with their sobriety program, they need trauma treatment, PTSD treatment, complex PTSD treatment, schema treatment. And there's a certain brand of substance abuse treatment professional who actually wants that, because they recognize that their clients are using in part because they're often being triggered from their traumas. And they're not qualified to treat the trauma, and I am. So we work together on that. So it's complicated, right? There's a lot of assessment as we go. There's a lot of helping people down the road. It's often a very long-term process. Similar to eating disorders. When I used to specialize in eating disorders, it was the exact same thing. Particularly if someone had it beyond a certain threshold, which they often did, they needed to be in a specific recovery program for eating disorders, not just therapy with me. And the specific treatment program often involved more support and more contact in between my sessions. My sessions are just once a week. You cannot treat a moderate to severe eating disorder in 1 hour a week. You cannot do that. In the same way you can't treat someone's trauma and their substance abuse recovery in 1 hour a week. It is not possible. You need, at the very least, to have like 3 or 4 contacts a week, if not 7 days a week. And in eating disorder treatment, there are day treatment programs, typically in American cities, where you can go to this treatment center for 6 hours a day and get some group therapy, get some education, but also be observed in how you prepare meals, some routine to that kind of thing. People there to help you resist the urge to purge if that's your issue. And so day treatment programs are often necessary. They're often covered by insurance, to my knowledge, but anyway. So I don't know what she's saying here, but I'll just say all that. Now, Dr. Darcy might say, yeah, absolutely, that's exactly what I do as well. However, I've heard people say things like, if someone comes into my office, and the other thing about this, I'm sorry, I'm rambling, is that what if it's like a marijuana addiction, which in my experience, if they're smoking a joint every night after work, or they're drinking 2 glasses of wine, 3 glasses of wine every day at dinner after work, then in my experience, it's not highly likely to interfere with therapy. I'll address it and we'll talk about it. If I learn about that, I absolutely will say, well, let's talk about that. Let's talk about how that might be stunting things. Let's talk about why you're doing that. Let's talk about how it might be interfering with your relationships. Absolutely, all those things. But to say to someone who, according to definition, has an addiction to alcohol or marijuana because they're using some amount after work every day, to say to those people, like, you have to get treatment before you come to therapy, I just find it to be simplistic, is all I'm saying.
Is very, very telling to who he is as a human being, and just like how unaware he is about how he presents and how much of this is his responsibility. One of the most damning parts of having a personality disorder is that the person with a personality disorder is often so hypersensitive to any honest feedback and critique that they like bristle under it. And so they surround themselves with yes men and women.
Yeah, not always, but it is a tendency for people. And if you have privilege and power, then you're more likely to do that. I think this is obviously Amber Heard and Johnny Depp's level of privilege is so high and out of the ordinary. A more common example is someone will be at work, and if they have power over who works with them or who feels comfortable around them at work, they will often engineer subconsciously a group of people that are conducive to their personality disorder. I've seen this actually before firsthand. People who have a personality disorder based on relational traumas growing up will create what might be called a toxic work environment, because if you come into that circle at work and you have proper boundaries and you don't have the kind of relational traumas that fit well with this boss, then you will react against, or at least slink away and not get engaged in what they're trying to engage you in, such that you'll either just quit because you don't want to work under that weird emotional environment, or you'll be fired or transferred or something. And there's a selection process that will garner a certain group of people around that person with power that fits well with their relational traumas and their personality disorder. Often it's other personality disorders, or maybe even the same personality disorder, or let's say the same type of relational traumas that these subordinates went through during their childhood that actually fit well with the boss. And there can be some very bizarre mutual projective identification processes that can happen in these relationships where you might have even observed that from the outside, where you have a boss and a subordinate where they seem to have, the boundaries will often be blurred, and their relationship can often be extremely weird looking from the outside. Just like, whoa, there's something going on there. And it's often because of what I'm describing. So could Amber Heard and Johnny Depp do that as well? Absolutely. And just with Amber Heard's assistant, the way she talked, she seemed to frequently be bumping up against what she perceived to be a problem with Amber's personality, and eventually was fired. Probably, according to this conceptualization, who knows, maybe the assistant was terrible or whatever, but it could have been that the assistant had some of the commensurate issues that fit well with Amber that lasted long enough, but not enough of it, and thus at some point she started to draw boundaries with Amber, and then Amber fired her because of that. You know what I'm saying? So, I mean, who knows? It's hard to say.
People who just enable them, because nobody wants to deal with the nut that comes out when they set a boundary with them, or when they gently suggest that something might be their responsibility.
So that word, the nut that comes out, do we believe, given everything that Dr. Darcy has said thus far, that she has contempt or looks down on people like this? I wouldn't say that. I would say that her, the use of the word crazy, the use of the word nut, there were a couple other words in there. If she were a colleague and she were talking, I would think that she just has a lot of experience with it and understands that I understand that she's not looking down on those people. That's my take thus far, but I don't know. But I could absolutely see people hearing those kinds of words and being like, why would you use that word? Because and that's like, why? Like, especially when you're in a public forum and you don't know how people will react. You just want to be a little bit more careful about using judgmental language like that.
And so the two of these people would give any therapist such a run for her money, because neither one of them wants to be responsible, or neither one of them wants to look in a mirror. So at the point at which the addiction were handled and being managed, then the real work starts.
So you hear that language, right? Once the addiction is managed, then the real work starts. And that's a very common idea that I find to be sometimes true, absolutely, and sometimes the best treatment plan, but often not. Because in order for them to be able to withstand the urge to not use, means they have to be able to handle their emotions as a sober person. And in order to handle their emotions as a sober person, they need to recover often from their PTSD. And in order to do that, they have to be with a specialist in trauma to help them with that works alongside, parallel with their substance abuse treatment program. And I can't tell you how many times I've heard, because people will email into me and just say, yeah, I struggled my whole life with trauma and PTSD, complex PTSD. I would have these spikes in distress, and I was in such a lonely place. I started using substances to cope, and then I went to therapy and listened to your podcast, and I thought, I should go to therapy. And then thought about it for 3 years, and then eventually I said, okay, I'm just going to go. And I spent a few months finding a therapist, and I went, and they told me to go away because I wasn't sober. And that breaks my heart. It's like, for someone to finally get into our office and for us to just say, like, yeah, go away once you're sober, come back when you're acceptable to me. That's not what she's saying, but it can absolutely have that connotation, and it's not necessary, is the thing. You don't have to. I think that, and again, just to put a fine point on it, some people will criticize me, even listening to me when I was saying it earlier, that for me to engage in psychotherapy with someone before they're sober is to enable their use. Like, even though every session I'm checking in with their sobriety, I'm trying to convince them to go to a substance abuse treatment program. I'm trying to help them understand that they might be in denial. I'm doing all those things. And yet, regardless of all that, I will be accused of enabling someone's substance abuse by engaging in psychotherapy with them prior to them being sober, which I just find to be simplistic and I think harmful to clients that need our help.
Neither of those two has any inkling into how they look to the rest of the world and how they contributed to the toxicity of that relationship. I am not surprised that they were together. They were perfect for each other.
In the worst possible way.
Yeah.
Absolutely.
Self-awareness is really hard to teach someone too.
And the irony is that people like them would never seek out a therapist like me because I'm known for giving honest feedback. That's my whole identity professionally. And so the people that come to me are the ones that are open to hearing it. They would never want somebody like me.
Yeah, so there's a lot to say about that. On one hand, I guess on the negative side, one could say if you do have a persona that people know prior to contemplating hiring you, that gives the impression that you aren't open to people who have low insight, then yeah, those people are going to steer clear of you because they accurately deduce that you're going to be judgmental of them potentially, or scary or unaccepting or something, or pressuring. Insight takes years regarding personality disorders. So also on the negative side, it's possible that if that is true, which I'll take her word for it, that she's never or hasn't in a while had an experience with someone who lacks insight, and you're tasked with helping them from a compassionate place and learning that it's hard. When you really listen to people and their experience, you realize, oh, insight is hard, the way that the other host was saying. And so I need to tone down my assumptions about insight and volitional control over it. So that could be another effect of where her career has gone. On the positive or neutral side, there's nothing wrong with a clinician saying, this is the sort of therapist that I am. And so know that before you hire me. And therefore, I only attract people who tend to be ready to be confronted. And because that's the sort of clients that I like to work with. And I effectively put out my vibe out there. So, and maybe even by disclosure statement or in my initial interview, I make sure that clients understand this so that they don't hire me thinking that I will be patient with their lack of insight. There's nothing wrong with that. There's nothing wrong as long as you're very good at making sure that people understand what they're getting into before, because someone could say, yeah, I want to be confronted, and then they don't actually know that, because you don't know what you don't know, right? And then halfway through therapy, after you've spent all this time and money and effort and you've bonded with a therapist, she starts to say, I don't have patience, or she starts giving this indication that she doesn't have patience for the lack of insight, then that could be harmful to client. Now, I don't know. I'm guessing if she were here, she'd say, well, I would never do that to someone. I would be patient, but I tend to work with people that are ready for confrontation. And I'll say that the second therapist that I had, I actually was seeking that. I was 24 and I wanted someone who was confrontational. In my words at 24, I said, I want someone who kicks my ass. And I asked around and I was given someone that absolutely was that style of therapist, and it was what I needed, and it was hard. I would drive to therapy and I'd be sweating just like, with some sort of adrenaline reactivity of, oh God, I'm going to have to face things about myself that I don't want to. But I needed that, I needed that kind of blunt, honest talk, because also on the positive and or neutral side of what she's saying is that there are a lot of therapists who will, in an unhelpful way, quote unquote, how do I put it without stigmatizing things, they will not recognize moments where confrontation would be helpful. And they will either theoretically they're coming from that place of full acceptance, unconditional positive regard for a client, or they've mistaken that for total acceptance of everything a client does. For example, a pet peeve of mine is when clients will be cheating on their partner for no good reason, right? The only sort of justifiable moral reason why someone would cheat on their partner is if they're being abused or something like that, right? But if the relationship isn't going well, or your partner is distant, or I don't know, just you're having some conflict with your partner, or you're not getting the sense that your partner's in love with you anymore, that doesn't give anyone, in my book, the moral right to break a promise that you made to someone and fail to break up with them prior to engaging in another relationship. You know what I'm saying? So in the same way that it's immoral to shoot someone for no reason or to steal from someone, we understand that there are moral guidelines that, for the most part, cross-culturally, we all follow, right? There are nuances to that, right? And yet, you will find that when a client who is currently cheating on their partner will come into therapy, it's not uncommon. I don't know the rate, because I haven't seen any research. The therapist will blame their partner and say, well, I understand why you're cheating, because your partner is distant, or your partner works too much, or your partner hasn't paid attention to you in bed, or whatever. And there's a lot of that nonsense that therapists they'll just say, well, I understand, because we're trained to listen well, to have compassion, to show care, to have empathy, which you can do at the same time as recognizing that something is immoral and wrong, harmful, if you will. In the same way that if a client came to you and said, my partner is, distant and works too much, so I decided to poison his food. Like, no one would say that's okay, right? Well, cheating isn't obviously that bad, but it's on the spectrum of knowingly doing something that you don't have to do that is harmful to the other person. It's a far cry from poisoning your partner. So I don't but there's a line there. And so often, particularly when it is a identified woman who is doing the cheating, it will be blamed on the partner. And so that's an example of a style of therapy that one could argue is too accepting or not confrontational enough. Now, if those style of therapists are effective in their disclosures such that clients know that coming in, then maybe that would, also be ethical because clients know what they're getting into. But, sometimes clients need, in my book, a little bit of encouragement. It's not a matter of confronting someone like, what's wrong? Like, I've had that many times where a client reveals to me that they're cheating. I would never ridicule them, because why? I don't even think that way. But I wouldn't say it's their partner's fault necessarily, unless I felt like it was. I would also never go along with their enabling thoughts that it's justified, or that it's okay because their partner will never find out, or it's they're in love, so what are you going to do? These are frequent kinds of things I'll hear from people who are cheating. I'm not going to be like, yes, totally understandable, I totally get that. I would never say that without a major caveat to that, right? I would say, well, yeah, I hear that you're in love with this person, and I understand the impulse, but you understand you're doing something that's harming your partner, and they don't even know about it. And if and when they do find out about it, they're going to be devastated. You understand that, right? Like, I understand why you're doing it, and I'm not judging you, but I'm not going to let this conversation not identify the harm that you're committing right now. I don't want you to be ashamed of it, but let's just hold on to that as a part of the equation, right? Because I don't want them to be shamed. I want them to proceed through life in a way that is congruent with themselves, because there's often a part of themselves that they're in denial of, that they can't integrate because they're confused, relational traumas, whatever, and they are engaging in infidelity, and it feels good and it feels accepting, and they don't want to lose their partner because they don't want attachment loss. Maybe they have kids with this person, and so they don't know what to do, and through defensive structures, they cut themselves off from a part of their integrity, a part of their empathy for their partner, and they just go into a fantasy land that everything is okay, that everything will work out, that they're congruent with their soul and with their own moral values, which they are not in that moment, unless they're a psychopath, which happens sometimes. But so I'm helping them to sit with the gray zone that on one hand, they feel good about what they're doing. On the other hand, they don't feel good about what they're doing. And to bring both of those things into awareness is helpful in terms of how to move forward. Often it involves divorcing their partner, right? Or not cheating, or working on their current relationship. And I've been with clients as they go through that extremely messy process over the years. And if I just accepted everything that they're in complete, if I went along with their denial and accepted everything about their infidelity and their narrative thereof, I don't think I'd be doing them any favors. So it's not a matter of shame, because why? It's a matter of helping the client to fully realize themselves and who they are and where they're coming from, so they can make choices to meet their needs and to be in congruence with their integrity. Anyway, so yeah, but the umbrella concept I'm referring to that I don't often get a chance to talk about is that there is a style of therapy that it's just supportive, that I will hear sometimes. I'll hear accounts of some therapists who seem not to be operating from any theoretical orientation or any evidence-based treatment practices. They consider it their job to just affirm everything a client says. I imagine for these therapists, they had bad training, bad supervision, or they've forgotten their training, and it's just easier to affirm everything a client says. And you're gonna get a lot of clients that way, because clients feel affirmed every time they come in to talk to you, regardless of what they say. And now that style of therapy can be very helpful with certain caveats to that. There's a flavor of Rogerian and person-centered, client-centered therapy that's definitely in that direction. So it's not that being affirming and supportive and having positive regard is not helpful. In fact, it's very evidence-based. But I hope you get my point. And some of you might have even had a therapist like that, where they listened well and they nodded their head and they seemed to care, but they didn't seem to offer anything up, right? They didn't seem to say like, well, have you thought about it this way? And you might have felt like it was kind of milquetoast therapy, if you will.
I was disturbed by the doctor's minimization of Amber's suggestion that she had PTSD. Most people who have a personality disorder have trauma.
Yes, I was wondering where that was headed, and I'm like, this is an idea that I actually, that I talk about a lot, and I'm really glad that she's saying this. I even explicitly said, I believe, and when Dr. Curry was providing testimony, that it'd be unusual for someone to have both borderline and histrionic and not have at least some form of PTSD, because according to some research and theory, as I've said, you have borderline personality disorder and histrionic personality disorder. A subset of that is complex PTSD, and a subset of that is PTSD. Meaning that people with PTSD tend to have all the symptoms of PTSD plus more symptoms, and people with borderline have all the symptoms of complex PTSD plus more symptoms. The trouble is that the symptoms in that sort of research literature isn't necessarily coinciding with the DSM. It's more detailed, it's more experiential, which I find to be more useful, honestly. So that's part of the issue. It's like, how do you define borderline? How do you define complex PTSD? How do you define, PTSD is pretty well defined, and I don't think anyone plays around with that too much. But yeah, so this is good.
Their history, whether they're struggling with PTSD or not, I can't speak to that, but there is an absolute common denominator between people who are diagnosed with personality disorders and having lived through often developmental trauma as children that never got worked out.
100%. This is great, because a lot of people don't talk this way. A lot of people will talk about personality disorders because the common topic sentence of the etiology of the cause of borderline personality disorder is that it's like partially environmentally and partial genetic, right? And that some people who have borderline have never been abused before. And somehow that simplistic state, and it's all true according to quote unquote research that demonstrates that. But, I've gone down long, Jags, but just, a quick caveat on that is that in order to determine if someone with borderline has been traumatized, you have to ask the borderline individual. You don't have a time machine. You can't go back and observe what the child was going through. Also, trauma is in the eye of the beholder. Two people can experience the same thing, and one experiences it as trauma and the other person doesn't. And we don't know exactly why that is. It could be genetic. There could be a genetic factor that seems likely, a more active amygdala, this sort of thing, or previous experiences that set that person up. If you're a little bit more neglectful of a child, they might be more prone to anxiety, and thus when you do go through a divorce in a family, you're more prone to developing a sense of terror and trauma when your parents are fighting, or when there's court hearings, or when one of your parents move out, that kind of thing. So whenever I hear people talking simplistically about the cause of borderline personality disorder, it always bugs me, because I've never met someone with borderline or histrionic that we didn't land on a very sound conceptualization of the cause as being rooted in their relational traumas growing up. Often it's abusive, and an abusive history that is quite obviously traumatic and terrorizing to the child, but sometimes it's much more subtle. You can just have a bad match between the parent and the kid. One could be extroverted, one could be introverted. One could be more, active. The other person could be more shy or something. And this conflict of difference can compound over time from, day one through, 5 years of age, where slowly but surely this relationship becomes out of balance, and the child internalizes this sense that they're being emotionally rejected. And that can be terrifying to a child. When we think about trauma, often we think about, being at war or being, sexually assaulted or something. But to a 2-year-old, to be ignored, it can be terrorizing. It can create absolute terror in that child, that they feel like their parent does not like them. That can produce a tremendous amount of fear, sometimes much more fear than you would actually experience in war when you see someone dying, or at least the similar amount of fear. And those traumas are, in my experience, always present. Now, I can't scientifically prove that, because I don't know if the client is lying to me. I don't know if we're just spinning something. I don't know if I'm just interpreting a certain way to fit my model. I don't know if everyone, according to me, everyone has those kinds of experiences growing up to some extent. So am I just cherry picking because I'm looking for it? Could be, but that's the glory of my industry, is we don't know, because it's such a complicated thing to research in terms of cause of these. We barely understand any of this kind of stuff, and we might not ever know, because in order to know these kinds of things, we'd have to take 1,000 babies and raise one group of 500 babies in a way that was non-abusive, and we'd have to raise another 500 babies in an abusive manner, in a mildly abusive manner, in a way that is slightly less attuned to their needs. And then we'd have to compare the two groups and say, okay, who has borderline, who doesn't? And that's another thing. How do you define borderline? You get 10 clinicians in a room. How do we even know who has borderline? Some people will say they don't. Curry and Hughes both found opposite things. One said she has borderline histrionic, the other person did it. And they're both right, because they're looking at the data in a different way. So it's not a hard science. Anyway, but yeah, so I like what she's saying here.
So it is important for all of us to remember that hurt people hurt people. Healthy people don't hurt people. And when we do hurt people, we are apologetic and empathetic and willing to repair the wound that we create.
Yeah, we're all hurt though, so we all hurt people, and it's just a matter of degree. And even quote unquote healthy people, I would say, have a hard time recognizing when they have hurt people and apologizing for it, but yeah, I mean, what she's saying is generally true.
And what I read was that the doctor that evaluated her said that she doesn't believe that she has PTSD, because apparently PTSD is one of, again, I may have this wrong, but I do know I read this, that PTSD is apparently an easy diagnosis to fake, or the easiest diagnosis to fake. I don't know. I don't know if I buy that.
Yeah, I seem to remember something like that being said. And no, PTSD, in my anecdotal experience, is not the easiest diagnosis to fake. I would love to see the research on that. If I was to take a guess, the easiest one to fake would be major depression, maybe, generalized anxiety, maybe, a adjustment disorder. Now, which diagnoses are most faked in people's offices, I don't know. I don't know the research on that. Plus, it would depend on the sort of office, right? Yeah, PTSD actually is, in my book, actually would be quite hard to fake because it is such a specific experience. And when you are an expert in it, you know it well enough to know the hallmarks and the way people talk about it. So you could imagine someone saying that, you just read the symptom list online. Let me just Google it and say, so it's like major depression. So if we look at the symptoms on WebMD, because that's what a lot of people go to. So fatigue. Okay. So you just read that. You're like, oh yeah, I'm so tired. Okay. Feelings of worthlessness. Yeah. You know what? I just feel I have low self-esteem. I feel worthless all the time. I mean, although as I say that, if you were detecting feigning, a moderately good, competent clinician would ask some questions. So like, okay, when you talk about worthlessness and low self-esteem, can you give me more detail? But again, it wouldn't take long to figure out something to say to that, because I think all of us have at least some level of low self-esteem, right? Impaired concentration, insomnia, certainly sleep issues would be easy to fake and report on. Diminished interest in things, restlessness, recurring thoughts of suicide, significant weight loss, that kind of thing. So on WebMD, half of those symptoms would be extremely easy to feign. You just say, yeah, I've gained weight recently, I can't sleep at night, I'm tired all the time, I don't want to do anything, I don't even like TV anymore, I don't like watching sports. It'd be pretty easy to feign that. PTSD though, I've said this before, I believe, because I did a little survey as I was flipping through the long DSM, that PTSD has the longest symptom list of any of the disorders in the DSM. It takes up like 2 or 3 pages or something. It's complicated and not intuitive.
I don't know if if Amber were as diagnostically sophisticated so as to be able to meet criteria for one thing and not really have it, I would think that she would also have the self-awareness to have not met criteria for histrionic or borderline personality disorder, because when somebody's evaluating for that, the questions are very obvious what we're assessing for. And so I don't think that you can say, oh, I diagnosed her.
Yeah, but I think what Dr. Curry would say is I wasn't going off of Amber Heard's self-report of symptoms to diagnose her with the personality disorders. I was going off of things that I heard from her and my experience of her, but also reports from other people about her behavior, which I confidently concluded that she has this personality disorder. That's my guess.
With this, but I don't believe that she meets criteria for that, because it's very easy to fake this. I don't think that those two things go together to me. And I think it's important for everyone to remember that, again, people who are wounded are the people who wind up, we're not born with personality disorders. They're a maladaptive coping mechanism to a very dysfunctional environment.
Yes, good. It's not often that I hear people talk like this. It's not an uncommon point of view, but on the internet and in public spheres like this, it often is reduced to that simplistic statement that I said earlier. And so it's refreshing to hear someone say this sort of thing in such a definitive way, which the way she's talking is the way I believe. I don't usually word it this way because I feel like the people who know the research and know what's written about the cause of borderline personality disorder will refute that. I'll be like, well, he doesn't know what he's talking about because the research says so. I'll sometimes caveat it pretty heavily, but it's refreshing to hear someone talk like this because it is my experience with these individuals.
Childhood generally. And then the person just goes through life like the rest of us do, finding people who fit into their worldview. And if your worldview is a healthier one, you're going to surround yourself with healthier people. And for people who have personality disorders, the worldview is not such a it's not such a stable and secure one. And so the people they surround themselves with are going to reinforce those patterns of behavior that they learned as children.
Yeah. The other thing I'll say, and I've experienced this a lot personally, anecdotally, particularly at my university, because most of my colleagues are women, that sexism could be at play in terms of the reactivity towards her. I don't know, of course, I don't want to accuse anyone of anything, but I've experienced this firsthand for decades as a professor at my university, again, with a majority colleagues, women, where we will both say the same thing to students and have a completely different reaction from the students who, again, are predominantly women, if not 100% women, identifying as women. And I will notice for my colleagues, they will experience a lot of negativity, a lot of assumptions about who they are. Whereas when I speak as a man, it just gets accepted because patriarchy and misogyny and all that kind of stuff. So I have that privilege. And an example of this is, us professors will get together and talk about our experiences or try to consult about different experiences in class with students. And I'll hear the way my colleagues are treated by students. I am appalled. I'll hear stuff that, now it's not all the students, of course, but the unruly students, the 1 out of 100 students, those are the students that will mistreat a professor. And not always, but they sometimes do. They won't mistreat me though, but they will mistreat my colleagues in ways that I've never even seen in my classroom before. And I'm not a perfect professor, so I can't imagine that it's just because I'm better as a professor, right? It must be something about our gender that's playing into it, right? And yeah, so I don't know if that's what we're seeing here, that maybe she'll say some things in a bit that I'll understand all the hatred, I mean, not hatred, but the criticism of her. But I haven't seen that much yet. I'm just going to put that out there.
And so, yes, compassion is indicated with people with personality disorders, and also they need to do their own work.
Do you know, and if you don't know, that's fine, but do you know why, in this case, one question I have, and I think we were discussing, how is this not a violation of Amber Heard's HIPAA rights with her diagnosis being broadcasted across the world? I mean, I know it.
Yeah, it's a good question. I don't do this sort of work anymore, so I wouldn't have the precise language. And I don't think that Dr. Darcy does forensic psychology. So she's a clinical social worker. Maybe she has done similar work. I don't know. It's typically psychologists that will do that work. But so the precise language around why this does not break HIPAA and isn't unethical, I'm sure to an expert they would be able to rattle off that statement really quickly. But because I was wondering, I was like, are we going to see psychologists testify on their evaluation for Johnny Depp? Because I'd be curious about that. And people are saying, well, no, that won't happen because Amber Heard, because she is in her countersuit claiming that she has PTSD because of Johnny Depp, then you have to be open to being evaluated and having those evaluations by both legal teams be made available to the court. And if the trial is public, then that will be available to the public. So because you voluntarily sue someone on the basis that you have a disorder, a mental health issue, as a result of someone else, you have to allow all this sort of stuff to happen. I think that's the way I would answer that question. But, I'm not a legal expert, so what do I know?
It's in court. Do you give away that right?
She had to. Yeah, no, she had to. So when you engage in a lawsuit like this, where each partner is claiming emotional damages to the other, you have to waive your rights to all sorts of things. And the doctor that diagnosed her, I believe, was either court appointed or came through. I think he
hired her.
it's very possible. And I think it's I think it's inexcusable that her team didn't then turn around and require him to be evaluated as well.
Okay, well, the first part of that, she came out strong out of the gate, but then started to go into some other areas. And I thought that as well. I was like, so are they going to require Johnny Depp to go through this? Because one, it'd be interesting. Two, I think the jury should know if, for example, if Johnny Depp has a personality disorder, maybe even like psychopathy or something, then shouldn't that be available to the jury? But according to our legal correspondent, that's not how it works, that you have certain rights in terms of your privacy, and you only have to compromise those rights when you, say, sue someone for emotional damage that resulted in a diagnosis. Because that's a central part of the suit, right? That if she doesn't have PTSD, then she can't claim damages because she doesn't have the damage that she's claiming.
That's interesting to me.
Yeah, why wasn't he evaluated?
I mean, he should have been and should be. And here's the deal. If you're in a relationship voluntarily with somebody like that, apple doesn't fall far from the tree.
So this brings up a broader thing that I try to remind myself, which I will violate even, on this podcast sometimes, which is to stay in my lane. She is saying things that I know now not to be accurate. She said he should be evaluated, that, for the court to see that evaluation. And that's a legal matter. That's a legal question that requires legal expertise to evaluate that topic, of which Dr. Darcy and I don't have, because why would we? We're not lawyers. And sometimes as therapists, and particularly as professors, our heads get so big that we think that we know everything about everything. And I'm sure some of you have heard me say things that will be along those lines. I'll get out of my lane and act like I know what I'm talking about when I don't know what I'm talking about. And incidentally, I've always been that way, even before I was a therapist and professor. So it's just a personality flaw of mine that I regret. I was worse when I was younger, but I still have it, I think. I try to edit stuff out, and I will sometimes be like, what am I talking about? Because I'm just speaking off the top of my head. I don't have, sometimes when I plan, if I have a chance to take notes and stuff and plan out what I'm about to say, I'm less likely to do that. But anyway, so I apologize for that, but it's a reminder to us, regardless of what area of competence we reside in, that competence does not equal knowing everything, if you will. So, and it's even within my field. I will hear therapists, counselors, psychologists talk about, for example, personality disorders in a way that illuminates to me that they don't really know what they're talking about. They have the right to talk about it, so to speak, because according to a lot of definitions and a lot of standards, they do have the competence to speak on such things because they have the education and maybe the experience. But the way that they talk, I'm like, ooh, you clearly haven't treated people and have a deep felt experience of that disorder, and you're talking as if you do. So it's just a reminder, I'm just going to use it for myself, that I should stay in my lane. And because there's nothing wrong with saying, you know what, I don't know. I'm not a legal expert. And I think I hopefully sprinkled that in. You'd be like, I'm not a legal expert, but why can't they read? That's another thing that our legal correspondent pointed out to me. He told me all the reasons why, and it's complicated and I still don't really understand it. But apparently there's a very sound legal reason as to why Dr. Curry and Dr. Hughes can't have their report or notes in front of them. I still don't really, I kind of get it but it's complicated, right? And I know enough about legal stuff in courts and trials to know that it's so complicated that even if it was explained to me, I won't get it, and that's okay. I don't need to know everything, but I'll take people's word for it. So it's a reminder to me, and so I hope that throughout my talk on all this trial stuff, that sometimes when I dip into that language, I'm like, I'm not a legal expert, so I'm just reacting as a layperson here, but why can't we have our notes? Anyway.
Water seeks its own level. We attract what we are. So pointing a finger and being like, oh my God, I married crazy, doesn't look good for you.
Yeah, okay, so we're starting to get into maybe some of the language that would bother people. That is victim blaming, right? If forget about Amber Heard and Johnny Depp. If you're in a relationship with someone that's abusing you, to say it's your fault, because you you manifest the relationships that, I can't remember exactly the way she phrased it, but essentially it's your fault that you're in that scenario that's obviously not the way to look at it.
I would actually love to work with either one of them because...
I feel a lot of people in your field would, that's...
Not me. Hearing especially the way they approached therapy, like that would drive me bonkers. To have a third party contact me and I have to set aside 3 to 4 hours of my schedule at the end of my day, because that's what it looked like. It looked like Dr. Anderson at the end of the day. I don't know if we've gotten to that video yet, but we will. But I've reacted to that much. And then they show up an hour later and they never actually make the appointment with me, and sometimes they show up without the other person. No, I would not want to work with that kind of client. In my experience, by working with actually accommodating a client like that, I'm just enabling them to avoid working in therapy. I have my clients who show up to therapy the vast majority of the time. They're on time, they work hard, they're ready to go, they've thought about what they want to talk about, they make a really purposeful effort in therapy, and some of these individuals are struggling greatly. So it's not like they're quote unquote high functioning. They've got serious issues, and so it's not like they're not without their issues. So yeah, for me, preference wise, given what I heard, I wouldn't want to work with them. Now, if one of them were to say, I appreciate what you're saying and I'm dedicated, I guess I would interview them. I'd be like, well, what I'd do is I'd lay out some ground rules. I would say, my ground rules are, I don't want any third parties. You call me directly. And 2, if you don't show up to a couple sessions, I will terminate you within reason. If there's a viable excuse, absolutely. But I don't want to play a game here. If you're dedicated to therapy, then make it a priority, and I will work hard with you. But if you're only going to half-ass this thing, then I don't want to. That's not the kind of place I'm at in my career right now. Other therapists might be into that, but I'm not into that kind of thing. I would also say that unless you commit to weekly sessions for at least a year straight, then I also don't necessarily want to work with you, because it also sounded like they came in randomly, because they're busy people, right? They have careers and they're traveling a lot and that sort of thing. So now I would offer phone sessions. There might be an ethical issue if they're in another country, because I can only practice with clients in my state of license in Washington for the most part. But now, if someone like Amber came in to work with me, that is my specialty, if she has borderline history. So I don't know if she does, but if someone that had borderline histrionic came to me, yeah, that's my bread and butter. That's I feel like to some extent, that's, if there is a God or a universe that put me on this planet, that's why I'm here, because I have helped people with those disorders, and the gratification that I get from that is so profound. It's hard work. It's really hard work, because these individuals will sometimes emotionally attack me. I've talked about that before. It can be very grueling, or they'll fall in love with me and they want to be with me, and so it will involve a lot of intensity and a lot of countertransference for me as a therapist. But the gratification I get after a number of years of helping them to internalize a relationship that has boundaries, that's non-exploitative, that's not abusive, that's caring and compassionate, and dare I say loving to the individual, that they believe in themselves, that they're worth it, and that other people can be trusted, that opening up that I have experienced with clients and heard from people who email in or colleagues that do this kind of work, that kind of experience, it gives me chills. I mean, it's profound. I mean, you could literally be saving people's lives by doing this kind of work, because the amount of despair that these individuals feel and the suicidality they feel is quite intense. And so, yeah, now someone like Johnny Depp would be I don't know what his personality is like, because they haven't gone into it at all, at least thus far. And if I would want to work with someone like him, like I was talking about earlier, we would have a long talk about his substance use and whether or not he's willing to start working in parallel in a substance abuse program. But that one I'd be a little bit less enthusiastic about at this point in my career, honestly, because the amount of work that he has to do to get sober and to remain sober could be really distracting, I think, to the work that we have. So, but have I worked with people like that? Absolutely. But yeah, no, when I watch these people, I do not have that urge. There's certain people in the reality TV shows that I watch, like when I saw Mike and Natalie, Mike being from Sequim, nearby Seattle, and I just thought they were so close to understanding each other. There are a lot of couples actually like this where I feel like, oh, you're so close to understanding each other. Tanya and Sinjin maybe a little bit, because they had genuine love for each other, and I think that they're both good people. Well, they're all good people, but yeah, those people, not necessarily in individual therapy, but in couple therapy, I'm like, give me 3.5 sessions with them, because that's all they need. And yeah, so I'll feel that urge sometimes, but my practice has been full and closed. All my clients now are long term, and I haven't had a new client in years and years. So, and I don't have room in my schedule to add new clients. So there's a chance that it could be years before I take on a new client again. So there's that. And it would be completely hypocritical of me to accept a famous person like Amber Heard or Johnny Depp when I have turned down, a lot of others who have asked to add another slot to my practice. So, and that would just be playing. Plus, there are plenty of other therapists that could do wonderful work with them. So it wouldn't be my job to do that.
It would be a really nice, it would be a great challenge. Yeah. It would be a really great challenge. But it would have to be the kind of thing where it was like with any therapist, it would have to be my way as the therapist or the highway, because the level of negotiation and manipulation and pushing boundaries and testing and trying to dilute something that is known to work, that would be an endless conflict between the therapist and somebody, who struggles the way both of these two individuals clearly do.
Yeah, I don't know exactly what she's saying. So on one level, that coincides with what I was saying, which is that if they came to me, I would draw boundaries. I would have ground rules with them. Ground rules that I don't usually ever disclose in the beginning of a relationship with a client, because I just assume that they won't do the way that they were with Dr. Anderson, or at least my impression of the way they were. So on one level, yeah. Also, there's nothing wrong with a therapist saying, my style of therapy is, unless you're willing to work and you're willing to confront that you are responsible, then I don't want to work with you. It doesn't mean that you're a bad person. It's just not my style of therapy. I don't want to get into that kind of thing. And when I hear those, because I have supervisees sometimes that eventually come to that realization, and what I will do is we'll do a really detailed discussion and analysis of what they mean by that, because if that means what I think it means, they need to screen people with personality disorders prior to even seeing them in their office, which is hard to do because most people with personality disorders don't know they have a personality disorder. So they have to perhaps have a lot of false positives when detecting personality disorders to keep them out of their practice prior to them ever engaging with them, because they are not a suited therapist to work with someone with low insight and a personality disorder. And that's complicated. But some of my supervisees have come to that realization. Personality disorders are very difficult to work with. It requires a lot of expertise, a lot of patience, and it can really get under your skin working with people with personality disorders. It can stress you out. It can cause you to have nightmares, secondary trauma. You can, or just literally be traumatized by clients, by the way that they react to you in therapy, because personality disorders often involve a lot of transference. And so anyway, I don't know if that's what she's saying. On the other hand, if she's saying, look, I don't screen those people out, and I've heard stories like this. Many people will email me telling me stories like this. And I've actually had supervisees who were advised by other people to do this sort of work, and it always it really, really bothers me because, well, it'll become apparent. But so someone comes in, they don't know they have a personality disorder. They've had a very difficult life. They've had a lot of traumas in their past, and they finally go to therapy. They sit down and they start talking about things, and the therapist starts going, oh, this person like doesn't take responsibility for their behavior. They blame everyone else. And the therapist starts to confront that. You seem to blame everyone else. Well, now you're triggering the person with the personality disorder. They get triggered, they get upset, they reject you. There's sometimes messages from the client of just like, I don't like this style of therapy. And then, and this could, again, be 6 months in, and then the therapist says, in their mind or in consultation, this client isn't ready for therapy. And so I'm going to confront my client and say, look, unless you're ready to work, then I don't want to work with you. And, you can just imagine the whole conversation triggers more, and the person with the personality disorder blows out of therapy, and the therapist walks away and goes, okay, good job. I detected someone that wasn't ready for therapy, and c'est la vie, moving on in life. When in reality, what happened was they, and I say this as a way of really driving it home, people come to therapy because they have problems. I can't tell you how many times I would say this to trainees. It'd be like, because trainees, they bump, because there's this fantasy sometimes that people have, that, and I had this too, that when you hang a shingle and clients come in and they all want to work with you and it's all real pleasant. They project themselves into the client seat. They're a willing client, and so they're an easy client, as a lot of therapists can be easy clients. But a lot of people, but sometimes people come into therapy with problems such that they don't know they have a problem, or their problem prevents them from acknowledging their problem, or their problem is so big that it's hard to even swallow that they have this problem, or they don't even know who they are to evaluate if they have a problem or not, or they believe they're so problemed that they don't even want to look at that, or they believe people come to therapy because they have problems, and sometimes that presents in a way that interferes with your current plan of therapy. And so you have to adjust your plan to the client, not the other way around. And so, it really bothers me because there's a whole class of clients who are commonly being rejected 6 months into therapy because they have a known personality disorder and a known manifestation of that interferes often with therapist's plan. If you have a plan going in and the client doesn't coincide with that, how about reevaluating the plan, right? Or reevaluating your assessment or conceptualization of the person instead of just being like, well, they're not ready for therapy. Yeah, I can't tell you how many times I've heard this. And I know some of you have been through that because you'll email in. I don't expect lay people to understand personality disorders. I don't expect lay people to put up with the ins and outs of a relationship with someone with a personality disorder. Okay, but I do expect a clinician that presumably got into this field of psychotherapy because they care about other human beings, right?
Well, Dr. Darcy, I really appreciate you joining us. It's been really insightful. Can you let my audience know where they can find you and follow you for more of your content?
Absolutely. You can follow me at askdrdarcy.com.
Now, overall, if that's the entirety of it, I did not hear, I commented on some of it, but that's what this whole point is I'm supposed to react, and so I'm speaking about things that pop into my head, and there's an endless supply of that. But if I were just to watch this without doing a reaction video and provide like a one-sentence take on how offensive it was or stigmatizing it was, I would say it was low on the stigmatization. I would say that there were words in there that were stigmatizing, like the nut in them, I think she said, and she said the word crazy right out. I wonder if that is what really hindered her. I wonder if by saying the word crazy in the first sentence, it caused people to see everything it put people off, and then they just cherry picked things that they didn't like throughout. Now, could someone argue that she was stigmatizing to a certain degree? Yeah, you could make an argument. I might make a little bit of an argument like that myself. but certainly not the way I thought I would see. But overall, as I said before, a lot of the things she said, I'm really happy that she put out there. It felt really satisfying to me to hear another clinician publicly state about trauma being the cause of personality disorders, relational traumas. She didn't say relational traumas, developmental traumas, she said. There were a number of other things that she said that I absolutely commend her for. She knows how to speak well. So yeah, I think she's, on the average anyway, especially if she's a famous person that gets quoted. Yeah, she's way better than a lot of the other ones that I will, hear, like Dr. Phil or these kinds of people. But I don't know. Let me know what you think. Did you think it was off-putting what she was saying? Do you think it was sexist, that the way people were reacting to her? Will people attack me because I'm not attacking her? I don't know. We'll find out. And everyone out there, please take care of yourself because you deserve it. You really, really do.